This video you will learn OCD in children. Have you seen OCD in children? There is a OCD in children, not only adulthood, but it happens to childhood and teenagers. So OCD is a obsessive-compulsive disorder, and it happens in children and teenagers. So this OCD has three features. It has OCD and compulsion, and the obsession is intrusive. They have intrusive thoughts. They have unwanted thoughts, images, or impulsiveness. They have a compulsion, repetition behavior, mental acting to reduce their anxiety. The core features are time-consuming, distressing, functional impairment. Those are the core features. So obsession is commonly contamination. They are worried about contamination, germs and dirty, harm to themselves and to others. That's what they are worried about. That's what they are obsession about. They worry about germs, dirty. Their hand is being dirty, the floor being dirty. They worry about germs, forbidden thoughts of religion and sexuality. That's what they are. Odors, they obsess on odors. Compulsion, they have a compulsion of washing and cleaning and checking the doors and checking the safety and counting stuff and repeating things and ordering and rearranging and reassuring and seeking reassurance. I have seen patients who losing weight. They are losing weight because they have OCD. They want to clean 24/7. They cannot eat. They are suspicious from the food or the medication. And insight often limit verbal. Children, mostly they don't have insight of what is happening, and they cannot talk about that, may not articulate the purpose of the ritual. It increases family involvement and accommodation. Avoidance behavior is common. So OCD happens 1 to 3% in teenagers and typically begins 8 years to teenager years. It's rare in less than 5 years. It could happen, but it's rare. So it's 8 years or older. Mostly it's more boys than girls. Shifts to female when they become teenagers. So boys have OCD more, but more when they grow older. Girls develop more OCD than boys. So when they get teenagers. It is family link and gene link. So if one of the family has OCD, one of the other family member may have. It is genetically linked to families. It has many factors: genetic predisposition, neurological, serotonin dysfunction, abnormal corticoid, thyroid cortical circuits, environmental stressor triggers such as stress or trauma, infection related like Bandes hypothesis, chronic waxing and waning. It happens early. It has early onset and severity increases and continue chronically. More chronic it is, more it continue. If the OCD began when the child is teenager, it will continue in adulthood and it will become more severe and chronic. Untreated OCDs can lead to persist into adulthood. Prognosis better with early treatment and fewer comorbidity. What are some of the comorbidity of OCDs? Is a tic disorder, threat disorder, anxiety disorder, depression disorder, ADHD disorder. So if the child has tic related to OCD, they will be more counting and they will be more obsessed with order, and they will be less washing their hands or washing the dishes or washing the floor. OCD can be diagnosed with 1 hour or greater than 1 day. If they have this intrusive compulsive behavior, it has to be 1 hour a day, 1 or more in a day. Significant stressor, not due to substance or medical condition, specifically insight level, good absence. So you want to assess the OCD scale. You want to assess and use the OCD scale. For the children, Yale-Brown OCD scale. Young children may not verbalize OCD clearly, and differential diagnosis include normal developmental rituals, tic disorder, no cognitive component. Autism spectrum, the child may have autism spectrum and it comes across as OCD. They may have tic and they may have OCD together. They may have generalized anxiety disorder that acting like OCD, or may have OCD and you think they have a general anxiety disorder. They may have psychosis disorders. So the first line of treatment for OCD is cognitive behavior therapy, psychotherapy, exposure, respond prevention, Most often intervention, family-based cognitive behavior therapy for the child, and pharmacotherapy include and is the first line of treatment. It is SSRIs, fluoxetine, Zoloft, fluvoxamine. So SSRIs medications are the first line of treatment for OCDs. Higher doses often require response so it will take 8 to 12 weeks to be effective. Second line of therapy is clomipramine. It is TCA antipsychiatric medication, and you want to add that to antipsychiatric medication like Risperdal for severe and treatment-resistant OCDs. You can also have a combination therapy of cognitive behavior therapy. SSRIs are the best for moderate to severe OCD. Family and psychosocial features. Family accommodation can worsen the symptoms. Key interventions include psychoeducation, reduce inability, the rituals. You want to reduce the ritual inability to perform these rituals. School support, accommodation. So family accommodation, if the family accommodation is not working, the OCD will be worse. Prognosis is a partially remission, most common. So if they recover, they can relapse. It can also fully remission. Poor prognosis factors. Why the recovery is not successful is early onset. So if the child have OCD earlier, it's hard for them to recover when they are older. If the symptoms are very severe, it's hard for them to recover. If they have other comorbidity like the depression and other comorbidity that we mentioned earlier, it will be hard for them to recover. Thank you for joining me today. I would love to see you in my next video. Thank you.